Hello and welcome to the EMSNation podcast. I'm your host, Faizan Arshad, and on the line, we're continuing our CCTMC podcast lecture series. We have Dr. Chris Fulgar, the president of AMPA, the Air Medical Physicians Association. Hey, Chris.
Hello. Hey, Faizan. I'm very happy to be here and just continuing on with the CCTMC lecture series here. If you guys haven't had a chance to attend to CCTMC, I strongly encourage it. It's a very exciting forum which is sponsored by AMPA, ASNA, and the IAFCCP, who really speaks to the whole gamut of critical care transport and medicine providers.
The content that is delivered at the conference is incredible, and it's a collection and consortium of world-class experts, and the camaraderie and conversation amongst both the attendees and the presenters is fantastic. And this lecture that we're presenting was certainly no exception. It is entitled, Consider the Extraglottic Device, A History and Nuanced Approach by Dr. Mike Steuerwald.
Dr. Steuerwald has been involved in air medical transport throughout his residency. Now he is an attending physician and a flight physician with the University of Wisconsin MedFlight. He has a particular passion for airway management and especially alternative airway devices such as the extraglottic airways. He takes a fairly comprehensive and interesting look at these devices, and it's sure to be a great talk.
I personally learned a tremendous amount from this presentation. So if you think you know everything there is to know about advanced airways, think again. A fun fact, he very early on defines the difference between an extraglottic device and a supraglottic device. So if you don't know the answer, stand by and tweet us what you learned after you hear the lecture.
All right, great. So good morning. My name is Mike. I'm a flight physician retrievalist from the University of Wisconsin. It's my honor to be here today. Thank you for having me. If it suits you, please follow me on the Twitter. It has become one of the most salient ways that I think we communicate in this industry. So I'd be honored if you did. If you do choose to make any tweets from this particular lecture, please use the conference hashtag. Again, this really has become a fascinating modality of communication in this industry. This industry is so international, such an international scope of influence. It's amazing to me how much using these tools has allowed us to communicate more and more with our international colleagues over the last 5 or so years. So please do share thoughts in real time. I believe that every lecture should start with thank you. So thank you to the program committee. Thank you to my two great friends, Dr. Steve Carlton and Dr. Jim Ducanto, who are my mentors in emergency airway management and taught me almost everything I know. To my friend Dr. Bill Hinckley, who is another mentor, and all of you. I really do believe that the undivided attention of several of your colleagues at once is a precious thing not to be squandered. The opportunity really is how you affect change. So I see a room like this as the ability to affect change. So thank you from the bottom of my heart, seriously. All right. I gave a talk here last year. I showed this map. So this is where we are right here. This is where I went to elementary school, and I went to high school right over here. So Charlotte is my home. I don't live here anymore, but I consider it my home. So it's a great pleasure to be speaking here. Let me digress for a moment. A couple of these slides will look similar from last year if you graced me with your attendance at my talk at this conference. But this really is my passion and influences how I make decisions. So allow me this digression. This is a work called Good to Great. It's a text by a guy named Jim Collins. Jim Collins was a business school professor, and over the course of several years, published several texts. Probably the most famous is this one called Good to Great. And the premise of Good to Great is this. So there were several companies that he examined over time. Think of this blue line, okay, that just petered along, petered along, petered along, petered along, petered along, okay? So time on the x-axis, profitability. So this group of companies just petered along, petered along, petered along, petered along, petered along. And then all of a sudden, he compared them to other companies that were petering along, petering along, petering along, petering along. And then at one magical moment, they exploded, okay? And their profitabilities just went crazy. The premise of the whole book is examining what made these great companies different from these good companies, okay? He called this moments in time the good to great transition. And after really thinking about it and exploring the concepts that he put forth in his book, it just occurred to me that while companies and their profitability is really what he was talking about, there are ways that we, as a medical community and a critical care community, can affect good to great transitions within our own teams. So I've become obsessed with this idea of finding ways to go from good to great and affecting that transition. This is what I'm passionate about. This is my scope of influence, or my scope of interest, emergency airway management. The way that I try to affect a good to great transition in my team, whether it's my clinical emergency department, my academic department, or my transport team, is I fight the enemies. This is how I've decided is the way to affect a good to great transition. The enemies, as I see them, are the cognitive load of the situation and the impact of stress. Okay, so those are the enemies, and everything I do is trying to fight these enemies. So what's my goal? What's my goal here today? My goal is to fight the enemies, just like every other time that I speak on this subject or do anything to try to affect a change. So how am I going to do that? It's by increasing the situational awareness around this subject, the subject being extraglottic devices today. The meaning behind that, and what I mean by increasing the situational awareness, is that I want to increase and give you some background information so that if you do have to use a device in a rescue situation or in some other primary application situation, that you have enough knowledge of not just how to insert the device, but what its features are, why those features got placed in a certain way, and what the differences are between another device that you might be able to place so that you can make the most educated decision possible. Furthermore, if your transport team is considering going from one extraglottic device that may have been in bags for 10 or 20 years to something newer, to make the most educated decision with respect to the features themselves, not just which ones happen to be used in some other part of the house. Okay? Is that cool with everybody? All right. So this is not a talk about how to place extraglottic or superglottic devices. It's not a talk about why you should put one in versus an endotracheal tube. It's not about why you may or may not decide to put one in cardiac arrest versus an endotracheal tube. It's about the devices themselves and trying to increase the situational awareness around. Okay? Is that cool with everybody? All right. Please stop me if you have a question. We'll just kind of rock around. This particular topic is exhaustive. If you read the definitive kind of Airway textbooks called Benioff's Airway Management, this is about 200 pages of text. It's impossible for me to go over this in 30 to 35 minutes. Taming the Shrew is an educational blog I contributed to for a few years. There's a couple of podcasts on this subject. One where I specifically interviewed a guy named Jim DeCanto, who's an anesthesiologist out of Milwaukee. Check out Taming the Shrew if you want some more resources. Terminology is the big elephant in the room. Clarifying and clarity of the terminology is really where we'll take our biggest step. If we can remove some of the ambiguity in the terminology today, will have well succeeded. All right, so bear with me. There's some nuance, but there really is a purpose. All right, and you can change. You can be better at the end of this talk after having gone through these particular subjects. Okay, so EGD. Okay, everybody's used that term before, correct? Everybody's said, "Oh, that's our EGD," or "We're going to use an EGD." All right. What is an EGD? Okay. So an EGD is an extraglottic device, all right? What does that mean? So this is an old school photograph from an anatomy text, the Gray's Anatomy text. You see the base of the tongue here. You see the laryngeal structures here. Here's the epiglottis. Here are the vocal cords. This is where the esophagus would be. This hole right here is the glottis, okay, as we all know. Extraglottic devices are invasive airway devices that do not go through the glottis. They're extraglottic, okay? Not rocket science. Superglottic airways versus dual balloon devices. Who, including myself, has used the term superglottic and extraglottic interchangeably? Okay? It's pervasive in the literature. People usually pick whichever one that they think of first to use the term. Okay? So EGD, SVA, EGA, SVD, so on and so forth. That's not accurate. Okay? So now, as a group, going forward, let's use these terms just a little bit more appropriately with a little bit more nuance, so that when we communicate, we all know exactly what it is that we're talking about. Okay? So extraglottic devices are all of the devices that would be invasive airway devices that do not go through the glottis. Okay? They can be further delineated into superglottic devices, okay, or superglottic airways, and dual balloon devices. Okay, those are the retrologic airways, and I will show what that means in just a second. Okay, so EGDs is a whole family, all right, and that can be further broken down into superglottic airways and dual balloon retroglottic airways, okay? The superglottic airways are named as such because most of the material lives supraglottic, or above the glottis. The most classic example is an LMA, okay? So the ventilation point is supra to the glottis, and most of the material is. The retroglottic devices exist primarily posterior to the glottis, okay? So as you can see, those are the dual balloons. This is the KLT device that almost all of us, I would assume, have either at the most or at the least touch, but probably put into patients. These exist retro. Okay? So EGD is the parent term. SVA, dual balloon devices are kind of the big branch point between the devices themselves. Examples of SVAs are LMAs, what I call LMA style devices. That includes the iGel, the Cook AirQ, the AMPA Origate, and then the other kind of big group are the dual balloon devices. That includes the combi tube, the KLT, and other derivatives that are much more obscure. So like the Roush Easy Tube and a couple of others. Is that cool? Is everybody following? This right here, this is all you remember from the talk, is this kind of like terminology, this differentiation. You made a step. Okay? It pisses me off beyond absolute measure how much of the airway literature is marred by people not paying really close attention to the terminology that they use, because it actually makes things kind of confusing. So this is, I think, understanding of this level is really one of those ways where you go from being one of these good teams to being one of these great teams. I should just hold this. Sorry, I like to get into it when I talk, especially about airway dysnos. This microphone isn't like it, I guess. Alright, is everybody cool with that? Give me some headphones. Okay? Alright, awesome. Alright. So let me take you on a journey, okay? We're not going to talk about like awesome 80 bands, even though Journey is an awesome 80s band. But rather, I want to take you through a journey of the devices now, okay? Not how to place them, not why you should buy one versus the other, but let me take you on a journey of kind of how the device that you probably carry in your bag has come to you, okay? All right. I'm a big fan of checklists, okay, especially for critical procedures. So I'm doing a critical procedure right now, which is trying to affect change. So I've got my checklist for this talk, okay? I'm going to show some photographs of some devices. My checklist for each device is I'm going to give you the classification. I'm going to talk about what sizes they're available. I'm going to talk about what their generation is, and I will explain what that means. I'm going to give you their claim to fame, if the device happens to have a claim to fame. And then I'm going to talk briefly about can it be intubated through blindly, can it be intubated through directly, and then can airway exchange kits be used to exchange them, which is really something that we don't talk about enough, which we desperately, desperately should. Okay, we desperately should. If I had I do have a chair. I usually make the point to do this with stuff I really want people to remember. We desperately should talk more about how these devices are managed after we put them in. Okay, and that's something that we don't talk about in transport frequently. Okay, we're usually trying to simply use a device to either rescue a patient or manage their airway primarily when we put one of these in. We don't think much about, well, what's the next step? And in emergency medicine, we don't do that as well. It is of desperate consequence that we think about how these devices are managed, because I would assume that a fair amount of us in this room have experienced the extraglottic device or superglottic device or whatever that gets pulled out, and then it becomes a crap show to then later manage the airway, okay? Because there is some rate of pharyngeal edema. If the device was placed because of a difficult airway, it doesn't help, it makes it worse. So let's absolutely consider these as we move on. Okay, so remember the idiot in the like brightly colored shirt on the chair when you think about these devices again at this point. Okay, cool. All right, exchange devices. So what I mean by exchange devices are two. Okay, so the Aintree catheter is this blue thing. It's essentially a hollow bougie that you can put a fiberscope through, and you can drive this down the lumina of most superglottic and dual balloon devices. And after you do that, you get it in the trachea, you can pull everything out and essentially have a bougie in place before you actually do your laryngoscopy. So it's a pretty safe way of exchanging an extraglottic device. This is the ARC airway exchange catheter set. It's a similar device, except you put a fiberscope down the lumina of whatever you're dealing with. You put a wire down what's called a warping channel that's on the slot that's on the side of the fiberscope. And then after you got the wire you put a catheter over top, and essentially the same. The LMA Classic. So the LMA Classic is the quote-unquote original supraglottic device. It was invented around 1984 and started having widespread acceptance in Europe around 1988. It was invented by this guy, Archie Briljal. So he's a British anesthesiologist, or anesthetist, as they would say. And as you can see, on his wall, he's got all of his prototypes. Okay, this is a little bit later in life. This is probably a photo that was taken in the late 2000s, and this is a later on device that was his quote-unquote favorite device that he later invented. This gets me super excited as somebody who likes to MacGyver stuff. This was actually the original LMA. So the original LMA was a endotracheal tube that was superglued to what was actually a nose piece. So this was a nose piece that was used for dental procedures. It got put together, and Archie used it, and it made a great seal. And that right there is the genesis of millions and millions and millions of LMAs. So the LMA Classic. The LMA Classic had a boat that was a laryngeal mask. It's got a couple of bars that keep the epiglottis from holding into the tube. It's reusable and is rated for some ungodly number of procedures. Okay, so here's my checklist. All right, so it's a superglottic device. It is available in all sizes for all humans, from neonates to adults. It's a first-generation Superglide device. It doesn't really have a claim to fame other than it was the original. It can be intubated through, or not be intubated through blindly reliably. You cannot shove it in the tracheal tube through it and expect for it to go in. You can use all of those exchange kits, and you can't just shove it in the tracheal tube through it if you have a fire scope. Okay, cool. Any questions about that device? All right, let's move on. The LMA Unique. Okay, same device except it's disposable form. So if you carry the quote-unquote LMA now, you likely carry the LMA Unique, which is a very similar device except for the fact that it has the ability to just be thrown away. Okay? To my knowledge, there aren't many benefits of the disposable LMA to the, the reusable LMA to the disposable LMA. So I think the vast majority of people, especially in transport, they use just the really old school LMA, use the LMA Unique device. Okay, so LMA Classic was the original, LMA Unique is the disposable version of the Classic. Okay, everybody cool with that? The CommuTube. Okay, the CommuTube is kind of a historical, prototypical dual balloon device. Okay, it had two ports that we're all familiar with how it was utilized. This device is interesting because it has kind of fallen out of favor because of its cost and because of the fact that it's not available in sizes for all humans. But it is got a couple of benefits that people don't talk about with any regularity. Okay, so let's go to our checklist. It is a dual balloon retroglottic device. It's available in two sizes, one for kind of like short adults and one for regular adults, so not pediatrics. It is not got a generation because it's a dual balloon extraglottic device. Its claim to fame is just that it's got a lot of EMS history to it, and it is a device upon which a lot are based. It cannot be intubated through blindly. You can't just put an endotracheal tube through it. It cannot be intubated through directly. Okay, so you can't put an endotracheal tube through it and put a fibroscope through it so that you can just drive that into the airway. And an exchange kit cannot be used. Okay, so you pretty much have to deflate the balloons and try to intubate around it or just yank it out. All right. The claim to fame that exists for the combination tube that usually isn't talked about that may make it still have a role in air management and not just make it be obsolete is this. So the pharyngeal cuff is a little bit different than the pharyngeal cuff on some of these other devices, most specifically a KNLT. So this cuff is actually still made of latex. And thus, and most people think this is why, has a higher seal pressure than almost all of the other extraglottic devices that we're going to talk about, whether it's the dual balloon variety or the superglottic variety. So if you talk to anesthesiologists, they will tell you that this particular device has the highest so-called seal pressure, or if you just have to use a lot of force to ventilate a patient, or high pressures to ventilate a patient. This device might be the most advantageous extraglottic device for which to do that. Okay, they're kind of expensive, and there's only two sizes. I don't know if a lot of people, especially in critical care transport, who are moving specifically towards this device. Okay. This is the LMA Pro Suite. Okay, so everybody remembers Archie Brain from that first photograph that I showed. The folklore is that Archie was actually a fan of the arts. And he was a fan of the opera and such, and as such had a respect for the human larynx that a lot of other people did not have. So he wanted to create a situation where we were manipulating the vocal cords less than we would be if we were putting in tracheal tubes in everybody that had elective surgical procedures. So he came up with this LMA device. The original device, the one that was based on that dental nose piece and the endotracheal tube that he superglued to it, was not what he wanted to make in its final form. But as I understand it, they were limited by what they could do with manufacturing. So after the original LMA had garnered some acceptance, Archie redesigned it with a couple of specific features, and that came out and was termed the LMA Pro Seal because the seal was better. Okay, so the boat is a little bit longer. Okay, it has a built-in drain. The back wall is really where most of the difference is. So this back wall is got an extra centimeter or so of inflatable material, so that when you put it in and inflate it, it really seals at the base of the tongue because of this extra material. So that is where the Pro Seal comes from. The seal pressure of this device is much higher than the unique devices that were originally available. So this is a more capable device than the uniques. It's a little bit harder to place because all of these tubes are floppy. You had to put it in this like metal thing, but it is and it's more expensive. But it is thought of as the next generation element. Okay. So its classification is an SGA. It's available in sizes for all humans. It's a second generation device, meaning that it has a gastric drain port built in. That's when, if you hear the term second generation, anything in this particular realm, that's what tells you that it's second generation or not, is that it has that gastric drain port built in. It cannot be intubated through blinding. You can't shove an endotracheal tube through it. You cannot intubate through it directly with a fiber optic scope. But you can use one of those exchange kits for this particular device. Okay? The LMA Supreme, who carries these? Okay, it's got some EMS acceptance. It is the disposable version of the LMA Pro Seal. Okay, so the history for the device that your service carries is what we talked about, went from the LMA Classic to the Pro Seal to this disposable version. Most people will not say that the LMA Supreme is a quote-unquote disposable version of the Pro Seal if they're a purist because the boat is made out of slightly different material. But for all intents and purposes, it is. It has the same characteristics as the Pro Seal in terms of my checklist of questions. It has a built-in bite block, and it has a rigid plastic stem so that it can be inserted with relatives. Okay. These devices can't be intubated through with an endotracheal tube. That's kind of their downside. The intubating element. Who's used an intubating element? Okay, not many. This is a wildly capable device. If all costs were equal and space considerations did not exist, I would argue that the intubating element is probably what we should all carry, because it is a superglottic device that is got a very specific claim to fame. And that's it can be intubated through blind leech. Okay, so reliably, you can just shove it in the tracheal tube through it and have it go into the trachea. Upwards of 90% on a third attempt after doing troubleshooting maneuvers. It's expensive. It's only available down to a size 3. It takes a lot of space up in a kit, so we EMS don't use the device with any kind of specific routine. But it's enormously capable. Okay? The device also comes in a disposable version. Okay. The King LT. I would venture a guess that most of our services carry King LTs. Can I see a show of hands? Okay. Honestly, not as many as I thought. This is the state-of-the-art dual balloon device. Okay, it comes in sizes for pretty much all humans. In the United States, it's available down to a size 2. Okay, there is a size 1.5 or a quote-unquote white king that is available in other parts of the world and perhaps available in the United States now. It cannot be intubated through blinding. It cannot be intubated through with an endotracheal tube and a fiber optic scope. But an exchange kit can be used. Right? It is simple to place the device, and it's very capable. It has a gastric drain. You get the LTS version, and it also comes in a disposable version, the LTSD. which is what most of us have. The IDO device. Who's used an IDO device? Okay, not many. The IDO is a Superglottic device. It's an LMA style device. It comes in sizes for all humans. It has great seal pressures, but if you run into problems with it, there isn't too much you can do because you can't modulate the pressures in the cuff. Okay? It does have a gastric drain. It has a built-in bite lock, and it is relatively inexpensive. Right? So it's a Superglottic device. It's second generation. Its claim to fame is that it's got this goo up here, and it can be intubated through directly and with the exchange kits that we have. Who's got AirQ? Okay, not many of us. The AirQ is probably the easiest device to exchange intubating through it or with an exchange kit. It is potentially the one of the most nuanced with respect to placement. And that's because the cuff is a little bit different than the other cuffs. The tip of the cuff can sometimes roll back after it's placed in the pharynx, so you actually have to have some practice with it. It comes in a couple of different varieties. A reusable variety that's used in the operating room. It comes in a variety that is disposable. It comes in a variety that has a channel on the side that you can pass a gastric tube through. And it also now comes in a variety that's actually self-pressurizing. So it completely gets rid of the pilot balloon and just uses the bag when you squeeze it to inflate the cuff. So every time you deliver a breath, the cuff pressurizes. Every time you get rid of a breath, it depressurizes. So that's the AirQ. Available in sizes for all humans. It's second generation. If it's got this channel, its claim to fame is that it's very easy to intubate through and specifically designed for that purpose. Okay. AMPA makes a device called the Aura Gain, which is very similar to that LMA Supreme that we talked about earlier. It has that same kind of rigid L shape to it. It's got a boat that's a little elongated, maybe a little bit of a high back wall, not exactly the same as the LMA Supreme does. It's got a built-in gastric drain and very easily can be intubated. Okay. Long story short is this. Okay, so I just went through about 10 different devices. All right. And we talked a lot about some nuances that makes one different than the other, and how the devices kind of over time develop their features. All right. If you are going to make the decision to go to one versus the other devices for your kids, think about that checklist. Okay. If you want that checklist, call me and I'll send it to you. That's the level of detail that you should be thinking about when deciding to go from one device to another device, or when you decide to train on the devices. All right. That is how, in my estimation, in this particular realm, you go from, just having things that we throw in, just having LMAs that we throw in, the good state to the great state. We have AMPA Isis that we specifically got because it's got a gastric drain that's built in that we believe in, and it can be intubated through at the trauma center. We work with our folks at the trauma center to develop a protocol to exchange. That's the good state versus the great state. Okay? So I challenge you to go from that good state to that great state. All right? Because it's not hard. Nothing is hard. It's all just making the decision to affect that change. So thank you for your attention. I appreciate you humoring me with the nuances that we've gone through today. If I can be of help to you in any way, shape, or form, please just ask.
All right, folks, that was an unbelievable lecture. We certainly hope you enjoy. What would make us even more delighted is if you would consider coming to CCTMC in person and meeting the entire cast and characters in the following year, in 2017. Chris, tell them all about it.
Absolutely. If you guys would like to join us, we are in San Antonio in 2017. And if you would like to check us out on the website, we are at AMPA.org. That's AMPA.org. We have also put this together in association with our partner organizations, the Air and Surface Transport Nursing Association, as well as the International Association of Flight and Critical Care Paramedics. So if you guys are able to come to meet us all, we have a great group of people that all care very deeply about critical care transport medicine, and I hope to see you in San Antonio in the spring of 2017.
The best speakers, the best pre-hospital content. Need we say any more? This is Faizan Arshad and Chris Fulgar wishing everyone a safe tour.